Good evening and welcome to Healthcare Behind the Wall, the Crisis of Deliberate Indifference. I'm Julie Majors. I'm the director of the Prisoners' Rights Coalition. The Maryland Prisoners' Rights Coalition is governed by the directly impacted and supported by advocacy organizations and professional partners whose mission is to improve conditions of confinement for incarcerated individuals confined in Maryland state and local correctional facilities. We obtain these goals by advocating with the incarcerated, their families, and the community through public awareness, public policy, and administrative and legal advocacy. I want to thank everyone for attending tonight. This is a very important event. I want to extend our gratitude to the University of Maryland School of Law for hosting the event, for all of their contributions, and for the partnership. I want to take a special minute to thank Professor Lee Goodmark of the School of Law for her leadership and partnership on this event. Her interest in advocacy in these issues and help with organizing has just been invaluable to me and to the coalition. I want to thank organizers Jessica Burgard with the School of Law, Michael Gerlach and Ben Goldberg with the MPRC. Thank you to the amazing speakers we have here tonight who are lending their voices and expertise to this issue. I want to thank the contributors, Justice and Recovery Advocates and Reproductive Justice Inside Project. And last on my thank you list, I want to send a humongous thank you to the directly impacted individuals and family members all over the state of Maryland for their courageous input and personal experiences which have allowed for not only this event to happen, but for us to be able to advocate for them and improve those conditions. Without directly impacted people, none of this work can ever be done. For those that are directly impacted that are speaking this evening, another special thank you goes out to them because they are lending their testimony and they are going to be very helpful in creating change. No one truly understands the courage that it takes to share these stories unless you've actually been there and lived it. From the treatment and dehumanization that both currently and formerly incarcerated individuals and their families living with this have experienced, retaliation is a very real issue. And it takes a great deal of courage to stand up and share what's happened. And for that, we want to extend our deepest gratitude. I'd like to give our directly impacted speakers a hand for that. Imagine for a moment being locked in a prison cell for hours on end, sick, in pain, mentally and physically suffering for days, weeks, years, and you're completely disregarded when you request help over and over. If you're having a health emergency, like severe chest pain, seizures, you can't breathe, you're bleeding, and despite the screams for help, no one comes for hours, if at all. Imagine having your request for help ignored, torn up in front of your face, even when you file complaints over and over to be disregarded. Imagine knowing that if you keep complaining, as you have been told, that you will experience retaliation, and know that you now must remain silent for fear of worse consequences. Imagine these conditions worsening to the point of being disabled, permanently living with preventable health issues, even after release, and unfortunately, sometimes death. Imagine thinking every day, am I ever going to make it home? No one is going to help me. This is the case for incarcerated individuals residing in Maryland state and local correctional facilities with the current state of healthcare behind the wall. I probably hear that comment more than I hear anything else is please help me. I don't think I'm ever going to make it out of here. When we decided to launch the healthcare campaign, we knew this was going to be a huge undertaking, not only because it's somewhat uncharted territory. In fact, I've been kind of yelling for years that this is the one issue that affects everyone and it needs to come to the forefront. But there's also no transparency whatsoever within the system. And for years, there's existed this myth that incarcerated individuals get free health care. I mean, if that's what's free, I think I'll pass. But also because it covers a huge umbrella. When we say correctional health care or carceral health care or health care behind the wall, it covers medical care, chronic illnesses, infectious disease, mental health care, dental health care, which is one that a lot of people really don't talk about. Addiction treatment, nutrition, emergency healthcare response, legal issues, and huge barriers to getting recourse, disability rights, and issues specific to reproductive care, LGBTQ, transgender issues. So as you can see, there's this huge umbrella. Tonight, we will cover a broad brush of the state of correctional health care, the egregious issues, and this campaign will continue with many more events. The accounts you're going to hear tonight are literally just the tip of the iceberg. We filled thousands, and when I say thousands, like in a couple of months we received thousands. Thousands and thousands of individuals every day are suffering from neglect, untreated health care, mental health conditions, and it continues to get worse. I started my advocacy many years ago, in about 2006, and my specific work with conditions of confinement in 2016. And I have to say, I've seen a lot of really bad things in my time. I won't age myself, so I won't tell you how many years that is, but I have never, ever seen or heard anything more despicable than the neglect and the pain and suffering. This is a historical problem of a massive nature. So you might ask yourself, don't prisoners lose all of their rights when they become incarcerated? I hear that regularly. The answer is no. You might ask yourself, how is this legal? I say that a lot too. Simply put, the answer is no. But you're going to hear tonight the why and the how on how this continues to happen. The issue of healthcare neglect and indifference behind the wall is a civil rights issue. It's a human rights issue. It's an economic issue, a safety issue, in the bigger picture, a public health issue, and a very serious legal issue. Thank you again for being here and your interest. We will have a question and answer period at the end, so you can comment. I'd like to turn it over to Jessica Burgard with the School of Law, who's a law student here.
Hey, I want to thank you all for coming on behalf of the students here, and Julie for being so amazing and showing such vigor and leadership against almost impossible odds. I think it's really important that this event is taking place in a law school. Legal education across the country focuses on the beginning of the process. So we spend a lot of our time reading court decisions and analyzing what judges think. And it's easy to not think about what happens further on down. And I'm very proud of our school that every single one of our students participates in a clinic where we work with the community and provide access to justice for people that wouldn't otherwise have it. And that does involve, for many of our students, going into prisons. And I would just say that I think we really ought to be going even further than that. What we see when we visit prisons as clinicians is kind of a sanitized version, right? We see people in the waiting room. We don't see body cavity searches. We don't see people being tased. And that's part of the reality of being in prison. And so I think that as we start our careers and we're all members of this system, it's our responsibility to really understand the gravity of those choices that we make. And the school does a great job of preparing us, but I would just encourage everyone, volunteer in a prison, get to know some people. I want to give a shout out to my friend Dave Hartless, who is not here because he is serving a life sentence in Jessup. But it was me getting to know him that inspired me to turn my own life upside down and come to law school. And he's been a real rock for the 3 years that I've been here. So there's educating yourself, and there's also the chance to form real bonds that will be special in your life. That's it. And thank you again, Julie, for just educating us all.
Want to be disregarded, misdiagnosed, neglected, and made to feel less than. within correctional health care is for you. Before you dismiss me as another disgruntled inmate, let me take a moment to explain. My first day in prison was the beginning of what I thought couldn't get worse. I remember my intake like it was yesterday, mostly because the treatment has never changed, just the faces. I never saw a doctor until a nurse asked me what unrealistic, undiagnosed illnesses I had. When I told her of my autoimmune neurological issues, as well as a recent stroke that was diagnosed and left untreated, at that point she laughed and said it had been a while since she heard that. I also explained how my vision and hearing had been affected. She laughed me off and called the doctor in the room, where she told me to repeat what I had said, and then the doctor laughed and began to explain to me that my issues are not recognized and furthermore not treated in the Department of Corrections. When I protested and began to ask questions, both turned their back to me and said I was done and I could leave. Within 3 days, I was moved to a known prison only to have a repeat of what had happened at the first prison and be disregarded. After a week, I was told I would be seen as a chronic care inmate, which I took as I would finally be seen and treated for my issues. How wrong I was. What they had done was put a label on me, which put a target on my back, opening me up to be victimized and mistreated by healthcare staff and others. I became a problem inmate for medical rather quickly by filling out sick call slips and getting my issues addressed. Having issues with balance, standing, dizziness, sleep, and eating issues, as well as speech problems. After multiple sick calls, the main cure was rest and drink plenty of water. When you put in a slip to sick call, it takes a minimum of 3 days to be seen by a nurse who decides if your issues warrant seeing a doctor. 90% of the time it ends at the nurse. Now, if you are recommended to see a doctor, it takes another 3 days. Only to have the same nurse tell you have to wait until your chronic care visit, which happens every 90 days. And not by a specialist, for there are none, only general practitioners and nurse practitioners. No cardio, no neurological, vision, nothing. The only time that would happen is you have to be taken out to the hospital, which, if it happens, it's too late for you anyway. It was during my first 2 weeks that I saw a death firsthand. I go on a sick call for sores starting on my backside and was told that they were bed sores and that I shouldn't sit so much. At the same time, another inmate from my tier went for chest pains. He was told to rest and drink plenty of water and sent back with me. That night in the rec hall, he fell out again and again went to medical only to be sent back. 3 days later, going to lockdown, I asked another inmate why we were locked down, and he said the guy that fell out in the rec hall had died that night and had just been found after not showing up for sick call. Not knowing the guy, I was still overwhelmed with emotion, not being able to sleep or eat, not wanting to die in my cell. The whole issue really began to break me down. So I started putting in sick calls morning and night, not only to be treated, but also out of the fear of being dismissed by healthcare staff. And when I would be called to medical, I would explain my issues and concerns, only to be told maybe I should have thought about things like this before ending up in prison. I continued to put in sick call slips, and after 2 weeks was told I would only be seen in chronic care, and if I continue to put in sick call slips, I would be locked up for misuse of forms. By the next week, after being denied all treatment and meds for my illness being untreatable and unproven, I called my advocate. Within 2 days, I was moved yet again, and everything started over from square one. Still listed as chronic care, I finally, after 3 prisons and 7 months, saw a general practitioner. I quickly learned that chronic care had a limited of 10 minutes to address all issues, or you have to wait till the next chronic care visit, or through the sick call process only in an emergency. As I began to talk about my issues, the doctor raised his hand and said he had a full day to tell me what I wanted and leave. I didn't understand what he meant, so the doctor said he would give me the basics. Anything else would have to wait. That day I was given Motrin, Excedrin, Elavil, multivitamin, fish oil, and glucosamine. I learned later that everything chronic care inmates is given the same. Every chronic care inmate is given the same thing for chronic care, no matter what their issue. As I was leaving, I again brought up my bed sores and balance issues, and the doctor said not to sit so much, and that day he gave me a cane. My issues continually got worse. The emotional toll had become the norm, not sleeping or eating, and the pain had become regular, which chronic care said they couldn't help with or treat. Walking and the pain being constant not getting out of bed for 3 to 4 days, only eating when I could reach in my locker. The fear and sadness of what was happening to me was unbearable. Having other inmates fall out on the chair with others yelling and screaming and beating on their doors, pleading for help to come to no avail. And knowing in my heart of hearts that no one was coming for me either, I continue to put in sick call slips, only be seen 1 out of 9 times. And if I couldn't get out of my cell, no one checks to see why. One day a new CO was working and came to my cell and asked why I didn't go to sick call. I explained my issues and he said he would look into it. The next day, after not showing up for another sick call, a nurse came to my door and explained it's not their job or concern to track me down. And if I wasn't planning on showing up, to stop putting in slips and wasting everyone's time. So from that point, when things got bad, I had to just deal with it and wait for my chronic care visit. Otherwise, I risked getting locked up for misuse of forms. Walking had become an ongoing issue, falling inside and outside daily, as well as my vision. Eventually, a CO came to me and told me to stay on the grass unless I was dying or being assaulted. 2 days later, while the same CO was working, I fell again. The CO told me to get up and follow him. He took me to medical and told the nurse to fix the issue or he would. She said I would have to wait till my next chronic care visit. The CO said, "That's bullshit," and pushed me through the gate towards the doctor's office. He pushed open the door and told me to sit, startling the doctor awake. The doctor said he would handle it. After the correctional officer left, the doctor asked me what the problem was. I explained my dizziness, my balance, low blood pressure, vision issues, as well as abnormal pains I have daily. He shook his head and left the room for what seemed like forever. As the time went by, the fear of something bad happening started to set in. When he finally returned, he gave me a walker and said it was all he could do for me. I also had spoken of my allergies and asked for Benadryl and was told that it was used as a psych med, but he would give me something, which later turned out to be calamine lotion that he told me to add drops to my eyes for itching. When I protested, the doctor said I was vision impaired anyway, so it's not like it would make it any worse. After that day, I have only been allowed to see a nurse practitioner for my chronic care visits. One thing worse than dealing with my medical issues is the emotional toll of when is it going to be my time. Telling the nurse practitioner of my new issues only to be dismissed and made to feel stupid for not understanding the progression of my disease that has never gets acknowledged. Going to medical and being told you have no meds and they give someone else's meds, and when you complain, all your meds canceled and having to start again from square one. And after seeing multiple pass away for not getting meds, given wrong meds, and being disregarded completely, living daily with the emotional toll of the what ifs and when it's my turn, telling yourself to survive and not to give up, that you have a voice and someone will hear it. To date, I have never been treated for my chronic illness in 5 years. And now being permanently disabled and not knowing if I will ever make it out of prison, one of the hardest things is never being able to do the things I used to do with my kids. To now, by no choice of mine, to now become a burden not only to my family, but also to the state. Maybe instead of calling chronic health, being called chronic health care, maybe call it as it was truly become meant to be, which is called questionable health care.
So I think he did a really good job of explaining how you're treated when you actually do get to medical. I'd like to now introduce Caitlin Rayford to come up to the microphone. Caitlin is one of our directly impacted speakers, but she is so much more than that. I have had such a pleasure meeting her. She's a firecracker, and she's beautifully smart and has a lot of insight to this. So please welcome Ms. Rayford.
Well, thank you, Julie. That was quite the introductory. I want to start with the neglect portion. When I was incarcerated, I was stabbed. Let's just start with the brunt force. During that time, I received no medical attention for at least 18 hours. They took me down to bookings, they left me there, and actually cleared 2 counts and didn't know where I was at. Then, once I asked the morning shift what if I could go upstairs, I had blood all over me, as you can imagine. They said, well, who are you? An inmate? So they took me upstairs, and upstairs, I asked to receive medical attention, which was an ice pack. I got to clean myself off. I got to be somewhat bandaged up. But during an incident like that, you're supposed to receive a tetanus shot. I didn't receive that for a week. In an institution that has 5 levels and also had 4 different wings, it's about 20 different tiers. You would think that there would be a tetanus shot somewhere within the institution. Either I have irrational thinking or they just neglected me. The next thing that I would like to cover is the sick calls. So it's your responsibility to put in sick calls for bandage change, medication, infections, whatever it may be. But during an incident like that, if you do get an infection, you don't get seen for 2 weeks. They have no type of response when it comes to the sick calls. And there have been individuals that have chest pains. You're lucky if you get taken to medical to be seen for your chest pains. And during that time, they take you and put you in another cell and hold you for observation. Nobody checks on you. They just leave you there. And in fact, sometimes they lock the cell door while you're in this observation. So you're lucky if you can call out for help. And there's also the false recommendations. During my time of incarceration, I had stomach pains, which could have easily been summed up as ulcers or something. They refused to give me an ultrasound. They refused to take me to the hospital, which to go to the hospital is a very big deal, being incarcerated. That is the last option. And at that point, you have to have no heart rates, turning blue in the face, something dramatic has to happen. Clearly, being stabbed is not enough of a probable cause to go to the hospital. So, back to my false recommendations, given the fact of stomach pains, I didn't receive any ultrasounds, sonograms, anything. But I was told that it would be a good idea for me to think about getting a hysterectomy or a partial. At the age of 25, I see your face, yeah, I'm 25. And I still have a life ahead of me. I could potentially have kids or anything, but that was the recommendation. And there is no second recommendation, no nothing. You can't go to another doctor because there's only one. And I didn't even see the doctor. That was the nurse that gave me that recommendation. The next thing I'd like to cover is what I've witnessed. During my time of incarceration, I've witnessed suicide. I've witnessed people cry out in their cell, screaming for help just to go to mental health because they want to be seen, because they need help, because they're not receiving their medicine, or their medicine is triggering some type of depressive thoughts, and they just want help. And during this time, no one did anything. The officers answer back with retaliation. They tell you it's not their concern. They don't care. They don't even come down the hall to even check on you. And during this one specific incident, there was an individual that committed suicide. There was another person that committed suicide a couple months down the line, and they have no regard for any of it. There's also the elderly that are incarcerated, and the elderly, they have diapers. The COs, the nurses, it's their responsibility to take care of their medical needs, and they don't. It's us, the other women. I don't like to refer to us as inmates. The other women are the ones that have to feel that empathy towards one another and go and change their diapers, rotate them so they don't have bed sores, put them in their wheelchairs and take them down the compound so that way they can get a breath of fresh air. Anything. Talk to them. Give them some type of love. Recognize that they are still a human being. And if it wasn't for the other women that are there, that are serving time, they wouldn't be recognized. They would just be left in a cell, on a bed, with a diaper that's been foul for hours at a time, They're not receiving any medical attention. They're not being taken care of to any degree, and they're just sitting there waiting to die. Another thing that I personally experienced was wrong medicine as well. That is a common trend. They are forever giving the wrong medicine, but for me specifically, they've given me wrong medicine. I didn't take it. Because if you take it, I mean, you're lucky if you go to the hospital, so there's no point. But the medicine that they gave me, they're fully aware of my drug addiction, my past background. And one of the medicines that the previous directed impact speaker spoke on was a benzo. And that is what they offer for the chronic pain division, is benzos, which is amazing, because when you have people that are re-entering that have a previous drug addiction, now you have them addicted to some other substance because they're thinking that it's equivalent to a Tylenol, just a little bit more. No, it's not. The last thing that I really want to follow up on is the internal conflict that you go through being put in a position like that, right? If you think what I said was traumatic, imagine sitting there contemplating, do I tell somebody or do I not? If you have the privilege to be able to reach out to loved ones on the outside, do you tell them? Do you put them through the emotional stress? Do you take them through that same journey that you're going through, but if not worse, because they don't know what's going on during the hours that you don't call them? And if you do, and then they decide to try and help you, do you take yourself through the retaliation? Because the COs retaliate against you, the nursing staff retaliates against you. If 2 weeks is long for a sick call, you won't get seen, or it may take a month. You might receive the wrong medication, if you receive medication at all. You won't be the one that they'll rush to when you're contemplating suicide, when somebody hurts you. There is violence inside these institutions, and your life is always, always on the line. So you have to sit there and contemplate, is my health really that much of a priority versus my safety? And that's a day in and day out issue. You have to contemplate, is it worth going on lock? Because when you have an issue, such as chest pains, you might get seen, but you're going to end up on a lock unit, and God only knows for how long. And when you're on lock, you're stripped away from all the privileges of walking down the compound and banging on that door to try and even be seen. There is no walking into medical. You know, that might be a question, like, well, why don't you just walk into medical? You'll be taken out in handcuffs and put on the lock unit. And that's even more of a reason for them not to see you, because at that point, you're confrontational, you're aggressive. And then not to mention, you're already looked at as a number, you're already looked at as your charges, you're defined by that. So you're not taken care of. When people are incarcerated, they're literally set there to just die. And that's what they push for, hope for, or even just neglect. And that's what it comes to. So I just want to say thank you for everyone who came to support, all right?
Next, I would like to call up Sonia Kumar, who's a senior staff attorney for the ACLU of Maryland.
Hi, everybody. Thank you, Caitlin, and to the unnamed person for sharing your experience so powerfully. And I want to say at the outset that a lot of times the ACLU are treated like the experts on this issue, on the issues of prison conditions, and we're not. Anything we know from the folks inside who share their experiences with us, or their families who contact us to advocate on their behalf. And so I'm not going to stand up here and pretend to have good answers for you. What I do want to be able to share is some of the perspective we get just from the bird's eye view we receive I think it's fair to say on a daily basis, we receive complaints at the ACLU of Maryland about inadequate medical, mental, or other health care in the Maryland DOC, among in other facilities as well. It's not a problem that is unique to Maryland. It's a systemic issue across the country, the crisis of the lack of adequate health care in our prisons. One thing that I just want to clarify for folks is that, so in Maryland, the state prison system doesn't directly provide health services. We contract with private corporations to provide those health services. And one of the things that you learn as an ACLU lawyer is that there are a couple of gigantic corporations out there that specialize in providing, a lot of air quotes, providing medical or other types of care, and it's a multi-billion-dollar industry for them. And one of the things that we see, and part of the reason that it's sometimes sort of, we feel like we're at a loss as to what to do, is that the corporations just change places every 5 years. So Crisis is the company that is, since this year, providing medical services in the Maryland DOC. For the last 5 years, it was Wexford. For the 5 years before that, it was Crisis. And what we see is that the issues don't really change. There aren't material improvements from one provider to another. And part of that is because the issues we're talking about are structural, they're cultural, they're resource constraints, and they're all things that I want to get back to. But one of the most important things that I think that every person in this room or anyone who watches this video can do is to remind ourselves that we are paying for medical services. We are paying a private company for those services, and we should be doing everything we can to make sure we are getting every possible thing we can out of those contracts. That's not a solution. I honestly don't know what is a solution other than significantly decarcerating our system. But I think it's a really important thing to understand the incentives here, right? So you have, so Crisis as the state assigned a $600 million, more than $500 million contract with this private corporation to provide medical services, including everything from sick call visits to medical equipment like wheelchairs. Then we have a separate provider that does dental. Then we have a separate provider that does pharmacy. Then we have a separate provider that does mental health. And then we have custody staff that are also responsible for the administration of the facilities and helping to coordinate. All of those entities, part of what's so weird about the dynamic we've set up is that the consumer here is actually the person who's incarcerated, but the person with the entity with the power to enforce the contract, enforce what's accountable, is prison administrators, who will tell you all day, every day, that they're stretched too thin to provide basic, to do the basic things on their list, let alone making sure that the medical providers are doing all the things that they're doing. We should also acknowledge the structural issue of just chronic understaffing in medical and in custody. I think that's fair to say in the Maryland DOC, and that's a real issue. And it also makes it harder and harder to attract quality people to do the job because it can be very challenging. And there's a lot of pressure. I think if you talk to healthcare professionals who have been in the position of trying to provide services within the prison system, it's really difficult because it's like the folks who, it becomes self-selecting, right? Because you can only tolerate it for so long. And it also becomes, there's a lot of pressure not to humanize your patients. There's pressure from custody staff in particular to dehumanize your patients. And I think those are cultural things that are not going to go away. I do think that one of the I just want to reiterate though, we as taxpayers, as residents, should be making sure our state, our people are getting every iota of care they're entitled to under those contracts. And that gets me to both, I understand that there's legislation being introduced this session in Annapolis that would establish some kind of meaningful, hopefully, oversight of the provision of healthcare services. But I don't want to discount the importance that individual advocacy plays. And there's no substitute for a person navigating what they have to navigate, right? This cruel choice between, am I going to sort of risk retaliation and piss somebody off by saying, I don't think I got the treatment I need. That's one avenue. I think family members and our other supporters, if you have, who can call from outside and call and follow up with medical, I do think that's a real thing that you can do for somebody that I think can be important. And I think, I want to get us away from the sense that only lawyers can get us out of these problems, because we can't. I mean, the ACLU has been suing the crap out of prisons for decades, and the chronic failures of prison medical care continue. I do think that vigilance is really essential, and that it comes in terms of sort of your ability to help advocate for one particular person, your ability to advocate in the legislature, your ability also, I think, and I think this is the number one thing, when you hear anybody in charge of a bureaucracy is going to tell you all the great things that they're doing. We have this form, and we have this protocol, and we have these fantastic people who are working their butts off. But I think anyone who has, been in any bureaucracy knows that bureaucracies are hugely fallible. There's a huge difference between what exists on paper and what operates in practice. And my biggest concern is that we have, the DOC and the public officials will say, well, we have these contracts that say that we're going to provide all these services, and look at all these things, and we've put so much thought into this, and we have this protocol where we're going to, every 3 months we look at the number of people who filed grievances about inadequate medical care, and we're going to do this troubleshooting thing. And the reality is those are great ideas, but the practical reality is we all have that stuff on our to-do list that you just don't get to. And it's the same in this bureaucracy. And part of what I think we can be doing, both folks who have survived the system or trying to survive it right now, and those of us who are allies, is to continually draw. We don't even need to convince them to agree to do a whole bunch of new stuff. Let's just get them to start doing what they've already obligated themselves to do in their policies. And let's understand how important and critical that is. I also just, I also just want to, it is really, okay, as someone who works in an office where we hear all these screwed up things that happen to people, it is really just wrong that we live in a state that is relatively wealthy and is unable to provide basic dignity to people that we take into state custody. And I want to also just acknowledge that each little thing, sometimes I think people really are looking for a sensational story about what's happening. But I want you to know how many, just think about the indignity of each moment. Think about if you've gone to a doctor and the doctor hasn't really taken you seriously, and how crappy that feels when you're really sick and you're like, this isn't what's wrong with me. And you're doubting yourself and you're like, am I wrong? Maybe I'm making a big deal out of nothing. And having that happen over and over again. And we get complaints about things and this is a sampling, but a guy who's had a wheelchair for 12 years, okay, 12 years. A nurse says she sees him, she's looked on video and saw that he's able to walk around with his prosthetic. So they're withdrawing, they're confiscating his wheelchair after 12 years in the DOC. Another person who is unable to have an adequate supply of clean catheters, which is a real risk of infection. Other instances, one of obviously the cases that hit us the hardest are cases where we too are wondering, is this somebody who died a preventable death? But it's not just that, it's also all of the cases where we think, somebody lost a leg. Somebody had to, because their chronic condition wasn't treated. And each of those instances is something that just should not be acceptable, but it's also impossible for us to litigate every single one of those cases. And so the state and these corporations are completely eluding, simply because our capacity as social justice warriors is limited, they're eluding their actual responsibilities. The last thing I will say to people who work in the law and who know anyone who is a judge or a lawyer is I think there is one of the biggest issues in anything relating to prisons is the credibility gap and this presumptive refusal to believe someone because they're incarcerated or because they're associated with somebody who's incarcerated. And I think that the world of what we are seeing on police body cams, I think is, I hope, an admonition for those of us who need proof to sort of like help balance the scales a little bit. I think one of the biggest issues that we see is also just a refusal to believe people when they say they're sick, whether it's the doctors or the people reviewing the grievances that they file seeking care. So I'm sure I could ramble on in front of you for a really long time, but thank you to everyone who has been involved in putting this together. I'm hoping that we can sort of expand our capacity to provide support to the folks who are inside our facilities. Thank you.
The MPRC obviously concurs with everything that Sonia's saying. Direct advocacy is something that I do frequently, not as an attorney, but as an advocate. I've gotten very close, here we go with those again, with the wardens and literally going in and directly advocating for people who are incarcerated. They look at me like I have three heads, like this has never happened. And I'm like, well, it happens now. And it's very important for the community to get involved and for directly impacted individuals to feel comfortable and safe to tell their stories, because that's such a big deal. And the more acceptance that we have of them as patients in this regard, or as human beings who reside in your community, the easier that comfort level is going to rise. During the time that someone is incarcerated, it's the word dehumanization doesn't even describe it, and their health is directly impacted that way. So, Sonia's absolutely right. What is happening on paper is not what happens in practice. We just finished questioning the department on their practices, some of their healthcare practices, and we get a cookie-cutter version of policies that do not hold any weight, and we know that they're not true. And they answer differently every time you ask the question. So clearly, there's issues there. But the community can impact legislation. The community can impact things to change, and they can change that social stigma so that that culture is looked at slightly differently than it is now. So having said all of that, I'd like to bring up Professor Lee Goodmark with the University School of Law.
So I know that I'm a bit of a surprise. Lila Meadows, who was supposed to be speaking and who is the fellow in the Gender Violence Clinic, was stuck in Annapolis doing testimony on a bill that we're working on there as well. And so I'm her replacement for the night. And so I hope that I will do that creditably. Welcome to the University of Maryland Carey School of Law. It is lovely to have you all here. It is important that we are open to the community and having forums like this one to discuss these issues, which are so, so important to our community. Thanks to Julie, thanks to the MPRC, thanks to all of our speakers, particularly our directly affected speakers. I can't agree more with everybody who said what we know because of them. And so all of us who have degrees and other kinds of things, we don't really know anything except because of the work that we're able to do with our directly affected clients and friends. I want to talk a little bit about the back end of the system. That's the work that we do here at the Gender Violence Clinic. We represent clients who are incarcerated in parole and other kind of late stage proceedings. And we are constantly trying to figure out how do we get somebody out, particularly when that person is elderly, particularly when that person is infirm or is experiencing some kind of medical difficulty in some way. Because of our current sentencing policies, which are stressing longer and longer periods of incarceration for no good reason, we have more people who are aging in prison than we have ever had before. And one theoretical release valve for those elderly and sick folks should be geriatric and medical parole. But there are significant problems with both of those systems, and I want to raise those problems for you so that we can think as a community about what we might do to solve them. So while Maryland does technically have a geriatric parole scheme, it has failed to provide meaningful relief to the clients who need it. And that's for a couple of reasons. First, only individuals who are serving non-parolable sentences are eligible for geriatric parole. So only if your sentence doesn't allow you to apply for parole in any other way can you apply for geriatric parole, which is a significant barrier. That eligibility, all the geriatric parole eligibility does is it gives you the ability to be considered under the regular parole standards. It doesn't give you any special credit, any special leg up in the parole system because of your age, although we know that people age out of criminality. So even people the vast majority of our clients are criminalized survivors of violence. They are people who've experienced gender violence, whose crimes are often directly linked to that violence, people who were never going to commit any other crime, people who arguably didn't commit any crime in the first place, and who are aging in prison, who are not any risk. But that geriatric parole finding doesn't give you any leg up, right? Except to say now you can be seen under the regular parole standards. There is no special consideration of age. There is no special consideration of medical conditions beyond what is required by the regular parole statute. There is no requirement that the Parole Commission weigh those factors any more heavily. So even though people are at an age where they are exceedingly unlikely to commit further crimes, the Parole Commission doesn't have to pay particular attention to that. That's not a true geriatric parole scheme. Maryland should follow suit of other states by creating meaningful considerations for aging prisoners, and a good first step would be requiring the Commission to specifically consider and weigh age in findings related to the future threat to public safety regarding the underlying crime. So basically, the Parole Commission's got to figure out if it's going to be detrimental to the welfare of society when you leave. And one of the things that our statute should say but doesn't is that we can think about how old someone is and the likelihood, given their age, that they're going to be that they will be dangerous in the future in making that determination. So essentially what it would do would be to mirror the standards for medical parole, which sounds like I'm about to tell you that medical parole works, but medical parole has its own set of problems. So as Sonia has noted, and as all of the panelists have kind of alluded to, the quality of health care that folks receive in prison is appalling, and a big part of that is the privatization of healthcare, and particularly in these companies like Horizon and their complete and utter failure to provide even adequate healthcare, right? Even minimally adequate healthcare. So Maryland, medical parole consideration in Maryland requires a recommendation and an evaluation from a doctor. And the only way you're gonna get that while you're incarcerated is through Horizon or Wexford, or whoever happens to be in charge at that particular time. For most incarcerated people then, we're relying on Horizon to do that work. And if you're not familiar with Horizon's long history of the provision of inadequate health care in a number of different states, I would really suggest that you just go Google Horizon lawsuits, and you will see that Horizon is being sued in multiple states over the provision of health care. And that recently, I think in the last couple of days, Sonia, that in Arizona, in a case that's been brought by the ACLU of Arizona, the senior mental health provider for Horizon in Arizona testified to the absolutely appalling state of mental health treatment in Horizon-run facilities. So we're relying on an institution that has really shown no particular desire to provide even minimally adequate health care to do these evaluations that we need to get people out on medical parole. There is good reason to be skeptical of the willingness of employees of this state contractor to make recommendations impartially about whether someone needs medical parole or not. Healthcare concerns, as you've heard, are often written off, and they're not properly evaluated by Horizon staff, and not surprisingly, when we ask for help with medical parole, we are often met with nothing, right? Not a denial, just a nothing, that they don't respond, that they won't speak to us. And so that's one of the problems with the medical parole scheme. But on the flip side, some Maryland Parole Commission employees have complained that Horizon actually recommends too many cases that are not suitable for medical parole just because they don't want to pay for providing health care for that person anymore. So it may not be that they actually meet the standards for medical parole, they're just expensive to provide health care for. And when that happens, even if the illness doesn't qualify under the Parole Commission's, under the medical parole guidelines, just so that Horizon doesn't bear the burden of paying for that care. And when that happens, the Maryland Parole Commission takes the claims that Horizon makes less seriously. And so when we do actually get the evaluations that we need for some of the clients who should qualify for medical parole, the MPC looks at that and says, well, Horizon says everybody needs medical parole, we're not going to take that seriously. So it's this real double-edged sword where we can't actually get evaluations for some of the people we need them, but Horizon looks at people who are costing them money because of chronic care that doesn't meet the standards for medical parole, and creating an impression by the Maryland Parole Commission that medical parole is being misused. So, what do we need? We need to change the geriatric parole statute. It needs to actually give meaningful access to geriatric parole, not just for people with non-parolable crimes, but for all elderly people. And it needs to give age a bump so that age becomes a primary consideration in determining whether geriatric parole is appropriate or not. And we need a third party responsible for reviewing records and evaluating individuals for their suitability for medical parole, who's not tied to the Maryland Parole Commission and who's not tied to Horizon. Some kind of independent body that can help us do the work that we need to do to help folks who are so aged or so infirm that they really need to be out. Thanks.
Thank you. I just want to make an interesting comment talking about the age of geriatric parole. I always find it funny, I'm the one in these meetings that when people discuss these type of statutes, I'm like, well, then who's eligible? Because you just basically denied everyone who's incarcerated. It makes no sense. But the other comment that Professor Goodmark stated was bumping that age. And I find that interesting too, because you age quicker when you are incarcerated. If you do not get proper health care when you're chronically ill, it is medically proven that your life expectancy drops. So it just makes absolute sense. You know, even people with release dates that are aging may not make it to that day between the lack of health care and these crazy, insane, that don't make any sense statutes. That's what we're left with. So I'd like to bring up our next speaker, our next directly impacted speaker, Ms. Kia Bradford, who, another lovely woman that I had the pleasure of meeting. She is sweet and she's kind and she's motivated, and I'm so very proud to have her here tonight. Ms. Bradford.
So my name is Kia Gardner. That's just a typo. That's okay. But first I want to start off by saying, serving my 20-year sentence in Maryland institution, the Maryland MCIW, in 2010, I was at Patuxent, and I found out that I had a hernia. I kept on having pain all the time, over and over, in the morning time and nighttime. Like, I wake up with the pain, I go to sleep with the pain. At Patuxent, the more I complained about the pain, they wound up sending me to Bond Secure. And Bond Secure, they gave me a sonogram. The sonogram came back that I had a hernia, but when I found out I had a hernia, they sent me to MCIW, and that was in 2010. So 2010 to 2015, I was still dealing with the pain in my stomach, the bulge that was in my stomach. It was like a big knot, and it was hurting so bad. But MCIW would not do anything about it. They told me, just take a Tylenol, take a CTM, I'll be okay. Just drink some water, I'll be fine. There's nothing they could do. And the medical records showed that I had a hernia, but they still just didn't care. So the more I complained over and over and over again, they wound up sending me out to the hospital to get surgery. But it took 5 years before they sent me out to the hospital to get surgery. And when I came back, I just remember, like, I felt better, but I was still in pain from the procedure. And the doctors, they prescribed me to Percocets. And I was getting the medicine at the hospital when I was there, but once I went back to MCIW, they said, well, I don't have that. They gave me whatever they wanted to give me. They said, I don't care what that hospital gave you. You're here at MCIW, and we're going to give you what we want to give you. And in the prescription, it clearly said that the doctor clearly said that MCIW will prescribe you to Percocets for the pain. It wasn't like I was trying to use them to get high. I was just trying to use them for my pain. Well, eventually they wound up giving me Oxycontins. And I was taking them, but they just wasn't giving them to me when they were supposed to give them to me. They was giving them to me whenever they wanted to give them to me, which I was still in the pain. Being in the infirmary, it just made you feel like you just didn't even want to be over there because of how dirty it was. They wouldn't allow anybody to come inside and clean up the room. They wouldn't allow, they could come, but the room, they just said no, they couldn't clean up the room. So I had an open cut, and they didn't help me change my bandage. I could hardly get up because of the pain I was in, but it was just like they just didn't even care. Eventually, I begged to get out of the infirmary and just to go back to my housing unit. I felt that the other inmates could take more care of me over there in my housing unit than as opposed to being in the infirmary. So I went back, and I had a lot of people like help me. Then the next thing I want to talk about is me witnessing someone there have a seizure. She was in the room, she had a seizure, and it was just so bad. It's like the officers wasn't on the pod at the time. The only people that was on the pod was just inmates, and it was lock-in time, so of course it was at the end of their shift, so they was in a bubble doing whatever they wanted to do. And I remember me and another inmate calling, like screaming, telling them to open up the door because someone is she's seizing inside her room. So when the officers did finally come, they opened up the door, and me and two other inmates, we tried to help her, but it was blood everywhere. It took medical about probably about 45 minutes to an hour before medical finally came to help her. And when medical came, they did nothing. They just stood around. We had to carry her downstairs from the upper level to the lower level and bring her down just so medical can transport her over to the infirmary, transport her over to sick call just to make sure she was okay. But it wasn't our job to do that. But of course, we wasn't going to let one of our sisters have anything wrong with one of our sisters. So we carried her downstairs, and they helped her, but it just wasn't like they should have. It shouldn't have took us to carry her downstairs. Medical should have did it. Then I found out, it was something else that I found out was wrong with me when I had a mark on my shoulder. I had a mark on my shoulder, and this mark, it started off little. It started off like real little, like a little dot. It was on my shoulder, and over the years, I think it was about 3 years when the mark just got bigger and bigger and bigger. And then every 2 months or so, I'll get a rash around it. But it wasn't like a rash like around the whole mark. It was just a rash around the circle, not inside the circle. But I kept on filling out sick calls over and over and over again, but they said, oh, it's nothing wrong, it's just a birthmark. And I said, it's not a birthmark because I wasn't born with it, I just recently got it. But they kept on telling me, no, it's just a birthmark. And so I filled out a sick call. It took about 7 days for them to finally call me. I showed them, the mark was gone, but the rash was gone, but the mark was still there. And then they said, oh, well, it's nothing I could do until I see the actual ring around the circle. But over and over and over again, I complained about it, and they did nothing. Then, I guess the more I complained, or the more I wrote it up, which I really didn't want to because I was scared of the retaliation. But the more I complained about it, they said that they was going to give me a skin biopsy. But eventually, it was like I was waiting and waiting and waiting to get a skin biopsy, but they never did it. The mark was it's right here. I don't know if you can see it, but it's this big. And it just grew bigger and bigger and bigger. But when I finally came home, I found out that I was allergic to Batrums, which they gave me Batrums over and over and over again, every time I had a UTI. But I kept on asking them if they could tell me what was wrong, and they said there's nothing wrong. I found out I was allergic to medication, which they kept on prescribing me that same medication, when they could have did a blood test, or they could have did anything to find out what was wrong with me. Then I just remember more times that, like, us, the women, we'll fill out a sick call slip for a pap smear. And me personally, they told me I didn't need a pap smear because I already had one and I'm not supposed to get one for another 5 to 10 years, which isn't true. I mean, from what I was told, I know, like, years ago, before I got incarcerated, you're supposed to get it, like, yearly. Now, that's what I was still thinking. Like, maybe since I've been incarcerated for so long, maybe it was, like, 2 or 3 years, but 5 to 10 years? No, that's not true. And it's like, they just don't care. They treat you like you're nothing, like you're an animal. They just don't care. Then, like, the last thing that did it was when I witnessed somebody commit suicide. Like, she was stuck in her room, just, I mean, of course she was going through something, but when we told the officers that she was hanging, it took them so long to come and get her. Medical never came. They never came. It took me and another inmate and an officer to do CPR on her, to pull her down from hanging at the top of her bunk and bring her down and give her CPR. And medical never came. They came, but it was like, they came like an hour later. The ambulance, they came, I want to say 2 hours later. When she was gone, we wound up bringing her back, but she was brain dead. And it's like, when is this going to stop? They don't care. They do nothing to help you. And it's a shame. You go in there you go in prison, and you just go in prison to try to do your sentence, to try to do your time. But then you come out with more stuff wrong with you than when you came in. It's like, when is it going to change? That's why I'm standing here and I'm going to fight. I'm going to fight until it gets better. Because we shouldn't have to deal with stuff like that. We shouldn't witness stuff like that. We shouldn't be the ones that's taking on the responsibility of what medical is supposed to do. Maybe if medical would have came, maybe that lady, maybe she would have made it. Maybe if medical would have came, maybe plenty of people. I didn't personally witness the other people commit suicide, but this one lady, I'd seen her, and then that vision, it just stays in my head. Like, and did they call me over there to be seen for a therapist? No, they didn't. They never even called me and asked me if I was okay. They just don't care. But with that, I'm going to thank everyone for coming out. And we will make a difference. We will, the more we fight and fight and fight, they will get better. Thank you.
And next, I would like to call up Ms. Jody Boyd the third directly impacted person that another absolute pleasure to meet. She is very brave for coming here tonight. It was kind of a last minute thing, and I'm very happy she agreed to come here and tell her story. Ms. Boyd?
Thank you. I was incarcerated for 32 years, found out I had kidney disease, was trying to be seen. I think it was 12 years, took me to get seen, finally. They made appointments here at the University of Maryland. Officers refused to bring me, saying they were short on staff. One reason or another followed. It took me 3 months to get seen. And I made it. Here I am today, still fighting the battle, but at least I'm able to get health treatment. The ones I left behind are not as fortunate. I got friends back there, 4 of them that are on chemotherapy. Sometimes they get it, sometimes they don't. They falsify documents to cover themselves up so that they say, yeah, they've been receiving this chemo, when it's clear that we know they are not. What can we do to make a difference? That's what I'm here for today. Asking for you guys to stand with us for this fight. We can't do it by ourselves, and they clearly can't do it without our help. What do we do? That's my question to you. How do we make a difference? I'm standing up here trying to make a difference. I promised them I would, and here I am, a free woman with a lot of damage. Prison was not a place for people who are sick. People who are mentally ill are ignored. I've lost 5 friends due to suicides. I watched one from my room. Nothing I can do. I cried for help. Officers nowhere around. We kick, we bang, we yell, to no advantage. We got to make a difference. We got to reach out. Thank you.
There is no doubt that the absolute greatest voice that can articulate this is one of a directly impacted person, whether that's someone who is currently or formerly incarcerated or a family member. And oftentimes it's just as difficult for the family members to stand up and say something as it is for the people who are behind the wall. I just want to say that the family members do time with the people inside. And I know this all too well because I too am directly impacted. I have a family member who became incarcerated, and that's when I became an advocate. As protectors and advocates of the rights of incarcerated individuals, the coalition fields complaints daily. My mailbox is never not full. My phone never stops going off. All day, every day. And when I first started doing this and trying to learn legal barriers and barriers to being able to advocate, it was so frustrating. I know family members like me called 150 attorneys to say, does anybody do medical neglect cases? And they say, of course we do. And I say, it's for an incarcerated person. Of course we do not. That was the answer that I got 150 times trying to find someone to save my family member's life. Overall, we get grievances, or I should say complaints, I don't want to call them grievances, because that process is a total and complete utter nightmare. But we get them for all things, from segregation issues to parole, but your top most egregious condition of confinement is this umbrella of health care. So I want to share with you, just even though I have like literally 25 current ones on my desk alone right now, I want to share with you some of our examples. And for privacy, I'm not going to be using, obviously, their real names. The majority of these people are still incarcerated. Mr. B experienced a heart attack in his cell. It took 3 hours of banging on doors and windows by other prisoners before any attention was paid at all. And that attention was, if you don't quiet down, you're going to lock up. 3 hours, and they finally showed up. He made it to the hospital just in time. And the nurses told him he was about 20, 30 minutes away from dying. And he was back on the block that afternoon. Mr. Hauk was not so lucky. His daughter is one of our coalition members. His untreated health conditions caused him to die alone in his cell 1 month before he was being released. Ms. P was one of our transgender clients who went months being denied their hormonal replacement therapy and medication, and months of advocacy was required to get this medication, a simple procedure. Mr. S, he's one of my current ones. He had a positive drug test and has been denied his hepatitis C treatment until he completes a drug treatment program that not only does not exist at that facility, but does not exist in the Department of Corrections, because the Department of Corrections currently does not have a drug treatment program. So he's been denied as a punishment for being an addict. Ms. H was one of our pregnant clients who, upon incarceration at a local facility, was denied her medically assisted drug treatment upon entering a correctional facility, forcing her into withdrawal while she was in the last trimester of her pregnancy, which severely risked her life and the unborn baby's life. Luckily, both did survive. Mr. M has a kidney disease. He was in kidney failure. He went for surgery, but upon his return, because there's no follow-up care from the hospitals back to DOC, was refused the medication prescribed by the hospital physician where he was taken for that surgery to ensure the health of his kidneys after surgery, was placed in medical isolation, denied antibiotics for an accompanying infection that he had. This went on for weeks. His family did not speak to him for about 2 months. They contacted me. I had to advocate. I got him moved. I got him his medication. This person should be on a chronic care cycle to this day, and we are still fighting to get him listed as chronic care. Mr. C has been denied his mental health medication, or inconsistently given his mental illness medication for his mental health issues. He has outbursts, delusions, violent episodes, and he self-harms. This goes on all the time. He's one that we've had for probably 1.5 years, and periodically, they will actually, a lot of them call me and say, what is this medication? I don't even know what it is. I look it up, and it's for something completely different. The majority of the individuals, I will let you know, when they go up to Medline and they're told, take this is yours, and no matter what, you will be threatened with lockup if you do not do what you're told, even when you know it's not your medication. This is not only bad from a healthcare perspective, this is just plain dangerous. I will also tell you that we had an incident where we had I'll say, an incarcerated individual that was in duress, if you will, in the Medline, and he was given what they call a Skittles pack, which is mental health medication that does not belong to you. It ended up being Prozac, and they said, we see you're having a bad day. Just take this. Now, luckily, this man was much smarter than that, and I said I would love to see how that would work at a CVS, should someone be having a bad day, if we are able to walk up to the counter, to the pharmacist, and say, I'm having a bad day. You think that you can hand me some Prozac? I'm pretty sure that's not legal. But this is going on, and I will tell you another thing. They worry about contraband, and they worry about things going on in there, but when you're handing out medication like that, not only does this exacerbate the opioid crisis that we're in and the addiction crisis that we're in, but you could potentially be killing people. And it also kind of contributes to this contraband issue. Mr. Twigg has had testicles the size of tennis balls for the past 4 months. And every time he goes to medical, he is told to drink more water. That seems to be a very classic one that we do here on a regular basis. In fact, it's actually in some individuals' medical records to drink more water. I didn't know that there was any correlation between the two, but what do I know? I'm not a physician. Emily Butler, I will say her name, because Disability Rights Maryland has worked really hard on that case, and the MPRC was part of that case from the beginning. Ms. Butler committed suicide at MCIW. From all the reports that we have received, they neglected her calls for help. She hung for an extended amount of time before anybody even noticed. Just so you know, the policy on paper states that rounds are supposed to be done every 30 minutes. Clearly, 4 hours later is not every 30 minutes. And not only did she hang there, but everyone else witnessed this that was in segregation at the time. And then when they did cut her down and moved her into the hallway, they let her lay there for people to see as well. All of these people deserved a chance to live. Many of these people were there for nonviolent crimes. Not that it matters, because it doesn't matter what someone has done. They still have a right to proper care. Many of these people were going home. And I get to the reason I became directly impacted. My family member has MS. He is doing 20 years for a nonviolent property crime. He has not received, after being incarcerated for 5 years, any treatment for his MS. No standard of care, not even a below standard of care. I mean, I'm kind of accepting of a lot of things that go on, but no standard of care. He has not seen a neurologist in over 3.5 years, and only one time while he's been incarcerated and on chronic care has he been sent to an actual specialist, and the only reason for that is you're looking at her. Okay, and it took me months. Due to the lack of care, Mr. Mahaffey has been left blind, 70% deaf, and he walks with a walker. This is a man who used to be able to run and ride bikes, and his MS was relapsing remitting, and now it is progressive in its last stage, and that all happened in 5 years. He's received multiple incorrect medications that could have potentially been life-threatening had he not reached out and asked somebody what they were, and, inquired about that or denied them and faced retaliation. He constantly files complaints. He he's not scared of it. He will do it in a heartbeat. He has had them ripped up in his face. He's had been laughed at. He has been retaliated against. One person mentioned being a problem inmate. Oh yes, if you file complaints of any kind, even when you try to follow the procedure, you are told, well, that's medical, you're not allowed to do that. Now, we know better, right? We know better that there's a process and that there's an appeal, but they are told, no, you may not. And when you are incarcerated and you are dehumanized and you are put down that much, you believe that. You believe what they tell you. You don't want to go to segregation because not only do you not want to lose your sanity, what you have left of it, or your life, you don't want to lose visits, you don't want to lose phone calls, you don't want to lose every human connection that you have. They will give up their health care. They will sit in that cell and bleed out before they face that. When he went to see dental care, they pulled out 5 teeth in 1 day without pain medication and never gave him an antibiotic. I saw him that day, and they didn't even sew it up. They let him come to visits literally after the procedure, and I got to look in his mouth, and there was skin and all kinds of crazy stuff. This is typical for dental, from what I understand, like those complaints. Again, something we don't talk about a lot, but it's pretty bad. And standard procedure is definitely to give antibiotics after a procedure like that. Even with advocacy from the outside, he's my family member, right? So everyone in this room and who's going to be watching this knows darn well I am going to be on top of that. I'm going to get everyone involved, and I do. And it's still hard. There are barriers to what you can do, even when you try to follow the procedure, when they say, do this, and he will do it to no avail. There's barriers that the system puts up, and it's a lack of transparency that is unreal. Outside of the pain and suffering he's had to endure, I think the second worst thing is what's happening to his kids. I've had to be the one to explain to his children that he will never be the same. He will never see them clearly. He will never hear them clearly. He will never ride a bike with his son. They know he's sick, but they're children. And they know that he's coming home at some point, but that the place where he went refuses to take care of him. Let that sink in to a family member, like what that's like. There's no justification for this. And while these are just a few of the examples and a few of the things that go on, you know, it's this huge umbrella of problems, and sometimes we all get, even as advocates, we get overwhelmed and we're like, where the heck do we start? You know, what do we do? It reaches far and wide. It has such a harsh, immediate, and direct impact that it warrants attention. It's going to be a long fight, but it's going to be a worthwhile fight. As I stated before, how someone is treated or not while they're incarcerated directly impacts their life and what they're going to do when they get out. It directly impacts it. It directly impacts their family, so it directly impacts their community. Why should you care? Why on earth should you care about any of these people? When it comes to impact, it impacts reentry. It impacts their ability to acclimate. I just was in court on Monday arguing for addiction treatment, and I think all this time this person's been incarcerated and we're not giving them treatment, but please, let's open up that door. And what? It's not easy to get health care once you're out either. It's a process. You are mentally impaired. Some people have become disabled because of the entire lack of treatment. There's a million factors. And how are we expecting them to become productive members of our society if we have debilitated them to the point where they can hardly function? So that's going to affect recidivism and victimization, and public safety is always a top priority for advocates and for the legislature and for the authorities. Well, this directly affects public safety. It directly affects recidivism. They're bringing health issues home and through no fault of their own and into the community that the families are going to have to clean up. This is a mess that the system is making, that the families not only try to help with when they're inside, but that when they come home, we are cleaning that up. From a human perspective, these individuals were not sentenced to pain and suffering. They were sentenced to confinement, to rehabilitation. There's absolutely no rehabilitation going on behind that wall. It's only exacerbating the problem. They have a civil right to be provided with adequate health care. While I believe that the term for incarcerated individuals of adequate health care is a tad low, they do have that right. And I think that the problem lies in that definition, and solely based on the fact that they're prisoners is why that definition for them currently within our society is so far below adequate. That needs to change. Just because they're prisoners, that right to adequate health care should not change. In this respect, we should be calling them patients. They are patients on the other side of that wall. They are human beings. From a community and family perspective, being one myself, no family should have to advocate or hire an advocate I love my job, but no one should have to hire me to barrel down that door to save the life of their loved one. No family member should sit on the other side of that phone and wonder if they hang up, if that person is ever going to call them again. There is nothing in this world that justifies that, ever. There is no justification for a child to be aware of an imminent death of their father or their mother because they're incarcerated. It's absolutely ridiculous. And no family member should have to worry about someone being disabled when they come home because of a lack of care. The department states that these people are under the care, control, and custody of the department and the state. I know custody and control is definitely there, but I don't see any care involved in this whatsoever. How do we fix this, right? How do we begin to fix this? Like I said, this huge umbrella, how do we begin to fix it? We're taking bites out of that apple. And we want the community's advocacy and support in taking bigger bites out of that apple. We believe that advocacy should be done in many ways, that there should be community advocacy, public awareness, that there should be legislation, obviously, and of course, taking legal action when we can and when we need to. One of the glaring issues that has arisen out of the research and this campaign is the fact that there is no complete, consistent, appropriate, independent oversight and regulation of correctional health care. They are not bound to the same requirements as other entities are for regulating health care. When we've asked those questions, every regulating entity that they call a regulating entity is internal. No public record keeping, and their reporting systems are very bad. It's astounding that not only is the inconsistent grievance process as a whole broken, it's disregarding, it's laborious to the point that the majority of incarcerated individuals just give up. But the healthcare system not being regulated, I called the Office of Inmate Health one time to ask them what their process was for grievances, and they said, they file a grievance, we ask the medical department if this is true, and we concur with what they say. End of story. How is this possible? How are they not being independently regulated? Many of these issues are independently regulated elsewhere, so some of this could start to be solved by making sure that not just the access to health care, but the quality of that is regulated by independent parties. Sonia mentioned the piece of legislation that we are actually introducing. Delegate Jazz Lewis, the bill is in drafting right now, and it calls for completely independent regulation and auditing oversight. That is to include entities that have the patient's health care in mind, advocates, legal advocates, people that understand that side of things, medical professionals, mental health professionals, dental professionals, pharmacy professionals, people that know how this should be done. So, having said that, there's many other ways that we can expand not only services for people who are incarcerated, but advocacy for them. And if you would like to become involved with what the MPRC is doing as far as a policy or bills, please make sure that you contact us and any other bills, because we do conditions of confinement bills all the time. So please reach out to us if you would like to help advocate and keep apprised of what we're doing. So next I'm going to bring up Mr. Andy Cryan, who's counsel for the MPRC, to talk just a little bit more about what we can do.
Want to be disregarded,
Oh,
misdiagnosed,
I knew I would do that.
neglected,
I knew
made to feel
I would do that. Sorry.
Good evening, everyone. Tonight I'm going to be talking to you about punishment, deliberate indifference, and the Maryland Prisoners' Rights Coalition's upcoming Legal Services Department. So beginning with punishment, it's important to understand what punishment means, particularly in the context of prisoners' rights. Traditionally, the Supreme Court has defined punishment as different forms of torture. Some common examples of that would be being placed in the pillory, whipping, waterboarding, and of course being forced to listen to country music. But in 1958, this changed a little bit with a case called Trott versus Duels. In that case, the Supreme Court held that the evolving standards of decency would now be used to determine whether a punishment is cruel and unusual. Or, stating in full, the evolving standards of decency that mark the progress of a maturing society. The problem with this standard is that it's still evolving. And this leads to the standard of deliberate indifference. In 1976, the Supreme Court came back and they said that prisoners have a right to file medical claims to obtain relief for the denial or mistreatment of medical services. However, in order to do so, they have to establish a two-step process. First, they have to show serious medical need, meaning that the need is so obvious that a layperson could understand it and see that it's obvious, see there's a problem. And second, deliberate indifference, meaning that the correctional official or the medical personnel inside of the correctional department had actual knowledge and behaved with reckless disregard to that serious medical need. Now, this standard has created serious problems within the legal community and heated debate between not only many legal scholars, but also several justices on the Supreme Court. For example, in 1994, in a case called Farmer versus Brennan, Justice Blackmun wrote a concurring opinion where he argued that this standard doesn't make any sense because the second prong, deliberate indifference, ignores several obvious factors about prisoners and their suffering. For example, a prisoner could simply tell a correctional officer or medical personnel, I'm suffering from this disease, I need this medication, can you help me in this way? If the doctor or prison official disagrees with that prisoner, then in the court's view, they have no right to relief because it's simply a claim of mere negligence or simple negligence, as terms often used. The other problem with this, as Justice Blackmun and to an extent Justice Thomas argued, is that it really doesn't make any sense because traditionally, punishment under the Eighth Amendment and in prisoners' rights contexts is only imposed by the courts and prescribed by a legislature. Technically, correctional officers cannot impose punishment, so it makes this standard even more difficult. And it ignores, again, the fact that a prisoner could be obviously clearly suffering, laying there in the cell, and that's not good enough to establish a claim because you have to prove malice. You have to prove that the correctional officer or the medical official is acting with an evil disregard. So ultimately, again, we come down between this divide, even in the Supreme Court, between it doesn't matter and it's the thought that counts. But the biggest problem, even before we get to that process, is the exhaustion of administrative remedies. Because before a court would even consider a prisoner's complaint, the prisoner has to exhaust all available administrative remedies, as the quote goes. This was established by the Prisoners Litigation Act in Maryland or the Prisoners Litigation Rights Act, federal law, in 1996, 1997, respectively. So I understand this chart's a bit complicated, but keep in mind as well, this chart only accounts for adult prisoners in regular institutions. There's actually a separate process for juveniles as well as pretrial detainees, whether juvenile or adult. But essentially, there's a three-step process here that's really what it boils down to. You have to file an administrative remedy procedure, which is abbreviated as an ARP, sometimes called an ARP. Second, you would have to appeal that once it's denied, which 99% of the time it is. And then finally, you would have to appeal the denial of that appeal to the inmate grievance office. Now, ultimately, it's going to move down the line, and the administrative law judge will make a decision which can finally be appealed to either the circuit court in the state system or the district court in the federal system. But of course, and really unfortunately, the average attorney doesn't even understand this process. It's not something that's taught in law school. It's not something that was taught to me when I was in law school anyway. And it's not understood by most prisoners. And this may come as a surprise to some of you, but a lot of correctional officers and medical staff, they don't like being sued. So when a prisoner provides them with, this is my complaint against you, Mr. Officer, sir, I'd like you to sign this, it sometimes happens to be missing. You know, when I was in law school as well, we always had this mentality of, oh, well, you have a right to a lawyer, you're a prisoner, criminal law is what you always think, right to a lawyer. You hear it everywhere within our society. But the problem is, this is technically civil litigation. So it's not you get a lawyer, you automatically have a lawyer, because in the state of Maryland, there is no right to counsel. In fact, there's only 6 states in the entire United States where you can even have counsel appointed. So you don't get this typical vigorous representation of attorneys standing by your side like you see in so many movies and dramatized. I guess this is kind of how I always pictured representing someone when I was in law school. I was being that kind of attorney. You never get that kind of representation because you don't even have a right to it if you're poor. It ends up looking something like this. You get one correctional officer surveying hundreds of people. This is your legal representation, if you want to call it that, because when it goes beyond the sentence, when you're thrown in prison, you have no post-conviction relief after that one's been used as a matter of right. When that's done, when your sentence is done, when the number of years are set in stone, the Maryland Legal Aid will not offer its service to prisoners. The Public Defender's Office will not offer its service to prisoners. And the system of correction is not, quote unquote, correcting anything. So at the end of the day, we're left with a rate of recidivism in Maryland that's about